Good morning, everybody. I will give you a couple of minutes to find your seat. I know the doorway into this room is fiercely guarded. So I'll let you have a quick seat. Whilst you're doing that, I might kick us off with introductions, if that's okay. So, as you just heard, my name is Rebecca Richmond, Beck Richmond. I'm part of the team at Optum. I'm going to let each of our panellists introduce themselves before I set a little bit of context for what we're going to talk about today and then hand over to them. So, if I may, Barbara, I'll start with you.
Hi, hello everybody. I'm Barbara Hakin. I'm a doctor, GP by background, but I spent 20 years in management. I was lastly Deputy Chief Executive NHS England, and I work with an eclectic mix of independent sector companies who are trying to help bring innovation to support the NHS, of which Optum is one.
Hi everybody, my name's Jim. I'm a GP, still practicing with a background in CCG and federation work, and I work at Optum helping to design products that help clinicians do better work and support their populations, and I'm also heavily involved in the delivery of our population health management work.
Good morning everyone, my name's Vic Townsend. I don't have the wonderful list of achievements these guys do, but I'm the Programme Director of Population Health Management in Lincolnshire with a background in system transformation.
Thanks all three of you, and again, thank you all for joining us today. I think one of the things that we really wanted to achieve today, apart from trying to cram as many buzzwords as possible into the title of this to lure you into this honey trap of population health management, was to really start to get into what population health management really means in 2023. I think it would be insulting of me to suggest that Optum invented it, that the NHS invented it, but the reality is it is becoming an increasingly prevalent focus point for a lot of the work that we're involved with, but that we see happening across systems, and certainly in a lot of policy that's out there right now, which has kind of caused us to think about, well, what does it really mean? Right now in 2023, when you think about the enormous pressures across the health and social care system, but also the massive pressure that populations, communities are facing more broadly, what is the opportunity for population health management? What does it really mean? And how can we talk about it as something that isn't additive, but something that actually could help systems, human beings within those systems, both in terms of our teams, but also the citizens and patients that we got into this for, actually try and tackle some of those broader challenges that they're facing in their lives. So we've got about 4 or 5 minutes for each of our panelists to share a little bit of their perspective around what PHM can mean from an integration perspective, what it's really all about in terms of starting with the data element, but then also trying to bring it to life, tackling the inequities that we know are so prevalent across most of communities right now, and really focusing in on that human angle. So, Barbara, if I can, I'll start with you.
Thanks, Beck. Yes, hi everybody again. And looking back, and I'm not going to start with sort of doom and gloom, because I suspect every session at the Confed this year could be doom and gloom, but it's now over 50 years since I started in the NHS. But I don't think times have been quite so difficult and quite so hard as I see them now, for all of you still working within the system. But actually, we face the same problem as nearly all developed countries. This is not peculiar to the NHS. We've got an ageing population, there's more we can do for people, different demographics. So it's always going to be an uphill struggle. And whichever plan you look at, whether in this country or internationally, there are two really strong features about what's going to help us to be the best we can be in these difficult circumstances. And for me, those two are predominantly prevention, treating sooner, earlier in the course of the disease, and innovation, and particularly innovation with regard to technology. And I think that there are huge hopes pinned on what technology can bring. Personally, I believe that technology will do for the health system and healthcare what pharma did, the revolution we saw as pharma was doing many years ago. I think we are entering an age when that is going to happen with technology. And there are many different kinds of technologies, but the one that underpins everything is data and analytics. And the rich vein of data and analytics that we have now, the ability that we could have to use that to the benefit of clinicians and patients is absolutely enormous. And of all those advances in data analytics, I think population health management is probably one of the oldest and one of the most advanced in what it does, and one of the most important, because I think in terms of preventing ill health and being cost effective for the NHS, pop health management has so much to offer, and it's not new. I mean, if I look back, I think that, and I am now looking back a long way, but in the early 90s, I was part of a programme about bringing in community matrons. Interestingly enough, the two, that programme was done with Simon Stevens, when he was a special advisor in Number 10, and UHG. So, you know, we are still carrying on that relationship and that understanding that we have. But community matrons, yes, we didn't have the sophisticated pop health management analytics we had now, but we were able to identify those patients for whom you could do something extra, for whom you could do more, in the hope of preventing them from a hospital admission or some other episode of ill health. But one of the lessons I think I learnt in those days is that however much you're doing with prevention and technology, it is about partnerships and collaboration and people. And it was interesting because I was PCT chief exec at the time, and the first community matron that we got, we employed in the PCT. And it worked reasonably, and she went round the practices and did quite a lot, but there was something holding it back. So then went for a second one, and we actually got the practices to employ the second one and to choose who it was, and it revolutionised several practices working together. So I think that, you know, collaboration and ownership and just making sure that clinicians are involved in it is so important. So I'm really interested to hear about the more detail about the work that's going on nowadays, because it's so much more sophisticated than in my day. But for me, pop health management, it is fairly simple and straightforward. It's about identifying a specific cohort of patients with a set of characteristics, probably a smaller cohort of patients than public health. I think there are subtle differences between pop health management and public health. Then once we've identified those patients, using data and analytics to say what is the absolutely best form of treatment for that, what is gold standard for that cohort of patients. And then once you've done that, identifying the individual patients and making sure they get the gold standard. That's what pop health management is. It has a huge range of applications for all sorts of different types of patients, and I'm sure we'll hear some examples today of how that's worked.
Thanks very much, Barbara. And Jim, it's a great way to segue into some more what you're going to talk about, I think, in terms of the bridge between the data, the clinicians, the broader group of people that are trying to help the whole person. So over to you.
Yeah, I was actually thinking about this bottle of water. So anything exists in terms of both its current state, the detail of what it is. Now, a bottle of water is pretty pure, but it itself has a context, being on the table in this room, nicely air-conditioned, safe from the heat outside. And it also has a history. And so do each of us, and so does every patient that we see. They have the detail of their lives, they have the context that they're in at the moment, and they have the history. And to really understand how we're going to deliver the best care or help that person move on to the best next part of their lives that they can, it would be great to understand more of those three things. Population health management through the act of linking data helps us do that. For me, I felt that population health management incorporates four aspects of how we look at the challenge. The first is that linked data set. Currently, as a patient approaches the NHS or social care, they exist through a definition of the building they're in or the person they're in front of, which door frame they've gone through. So for me, they're a GP patient with a GP problem. Very rarely will I know the details about what's going on for them in the rest of their lives, some of which may be extremely important. Sometimes I really do know. But working with the voluntary and community and social enterprise sector, I learned that knowing someone, you may visit someone in their house, but if you know someone in their community, you really know about their culture and what they go through in an entirely different and sometimes much more intimate way. So the linked data helps us understand people in a richer vein. The second then that I've alluded to is the wider determinants of health. So knowing people outside a biomedical model can help them medically in a much better way. And Barbara, you mentioned the difference between population health management and public health, and sometimes that's a confusion, but for me, the interaction with a patient right in front of me and public health at sometimes a national level or even a global level has an intervening sector where you're looking at groups of people much more specifically and what you can do with them. So they're wider determinants of health. Then there's the concept of being proactive. So not just the reactive care that someone's been able to get to the front door of the NHS, which is for some people very difficult because they can't read the letters, they speak a different language, they have very poor travel, maybe they just lead chaotic and challenged lives. But before they get there, you can be proactive. The fourth is relationships. So through linked data, not only can you understand people better, but you can understand how, as different providers, as different roles, with different sets of how do I do a good job, you can link up with others and you can ask, how do we do a good job together by understanding the people we serve better? And I've really enjoyed seeing that come to fruition in teams when I've sat around newly formed teams using that data to understand those people differently and for them to gain a shared purpose around a newly identified cohort of people, just as Barbara described, and designing something new and specific. So each of you has one of those histories. Each of you will have likely been in contact with medical or hospital or any type of care and felt maybe that you weren't understood or someone was either talking down to you or not making it clear enough. So population health management is partly about identifying those things that feel unique about any individual and bringing them together into a group of people that you can then design care for specifically for them. And that allows a much more bespoke care, a much more effective care. Once you look at your whole population using data like that, you can first get a better descriptive understanding of what your population looks like, where the needs are, where the best opportunity for impact is. You can then look at a predictive element. You can say, well, what if that's how things are now, how are things going to be in 5 to 10 years? And then you can get a prescriptive view of all the things that I consider I may be able to do, which is likely to have the best impact on the cohorts that I want to describe. Barbara mentioned looking at cohorts of people. I remember seeing a patient who'd been who's living under a bush outside the library in the town where I work. He had significant, and still does have significant, alcohol problems. He had some funny symptoms that his friends were concerned about, and they sent him up to the practice using a taxi funded by a charity. He walked out of my consulting room absolutely saying there was no way he was going to go to hospital. And I think he went back to his previous existence. I was able to reassure him that the symptoms he had weren't dreadfully serious, although I would have preferred him to go to hospital and get checked out. There are some people that currently aren't going to be found using the data sets we have. But with the data sets we have, we can definitely bring to life people's lives and offer them care in a different and proactive way. Sometimes getting right down to an individual feeling like, I'm really understood and the system knows what matters to me. And for me, that's what population health management is all about.
Thanks, Jim. It's interesting, as the chair of a panel, when someone starts with an existential point about a bottle of water, it's always slightly panicking. But I think that you really brought that to life. And I should also have mentioned as well that Jim stepped in at the 11th hour. Dr. Mark Shenton from SNE, who should have been with us today, unfortunately had a personal issue and couldn't make it. So thank you ever so much, Jim, for doing that. And Vic, last but not least.
Thanks, Beck. I've obviously got a huge bar to reach now. And as I said earlier, I lead a population health management programme in a system, Lincolnshire in the East Midlands. Now, from my perspective, I'd like to share a little bit about the application of PHM and what it really feels like in the ground, reflecting what Barbara said about the changing environments we work with, and also, particularly with this question to the panel, the demands and pressures that systems are experiencing at the moment, and bringing in a new methodology can seem like a huge hurdle. So, first of all, a bit of context. In Lincolnshire, we now have a person-level linked data set which covers 100% of our population, and it includes primary care data, secondary care data, including mental health, acute and community, and also, interestingly, and it's generating some fantastic insight already, adult social care. So we're starting to get to a position where we're able to see the journey of an individual or a cohort or an entire population of 814,000 people through our system from health to ill health, and how that impacts on our services, our system, and most importantly, the outcomes for those people. And that data set resides within our PHM reporting suite, which also builds in health inequalities, wider determinants of health, and other factors such as social vulnerability, which gives us a unique insight. And I can tell you, we were talking about EORs and TIGGers earlier at the Optum stand, that we have a number of PHM TIGGers now in our system where people are saying, my goodness, I've never been able to see my local population, or in fact, from some of our chief execs, our system in this granular detail and at this level. There's two tools I wanted to talk about today. And it speaks to Jim's point about being able to see what's actually happening and impacting on our people, is the strategic segmentation model, which enables our system leadership to see our population and their needs from a high level. It organises the population in a way that we're able to look at what the outcomes are that we have ambitions for our people. It enables us to create a touchstone as well, which changes the dynamic in discussions in leadership forums where you can gather around a shared understanding of the needs of our people, and the decisions that we now make can be framed around shaping our system to our people, rather than the more traditional aspects of shaping our people to our services and our organisation. And it removes boundaries. It levels the power balance to a degree where you can use the population health data to identify who the stakeholders are that you need in that room. And that might not just be your statutory organisations. Very often statutory organisations will meet first, try and get our house in order, and then invite in other parties potentially when we identify we might have a challenge or an issue or a gap. We try to start from a position of having everybody in the room, wrapping around wider determinants of health and equaling that power balance between some of our bigger statutory organisations and our smaller, potentially third sector partners and community assets. Now, that framework that we create is all around designing a supportive and empowering framework for people to work within our system to do the things Jim's talking about, which is working with smaller cohorts, to your point, Barbara, and working with my second point, which is smaller cohorts in our little, what we call Trojan mice. Beck knew I was going to bring up Trojan mice. I didn't know it had a name until the last couple of months. It's those small, fast-moving, adaptive pieces of work that enable us to drive forward change at a rapid pace in a complex system. And I loved the phrase Trojan mice. So that one stuck, and it's thanks to Helen Bevan. So our Trojan mice are our projects on the ground in our PCNs and practices that are looking to work with a small cohort of patients and people in their community from a biopsychosocial aspect, design new interventions using a PHM methodology with the widest possible MDT, multidisciplinary team from their community, and coming together collaboratively with a personalised approach to design and test a new intervention. And with PHM now, we can evaluate the impact accurately and effectively, and then make a case for change, feeding back into that system framework that has enabled and empowered people to work in a different way through that shared understanding and our linked data set. I think that brings me to a close. I hope that's been helpful.
Fantastic, thank you. We've got about 10, 15 minutes for Q&A, and you can use Slido to send in questions or comments, or I've been led to understand that we've got some plants in the room, so there is a raving mic if you want to ask your question live. We've had one come in on the Slido about some of the barriers to successful prevention and whether part of that is our sort of poor operational understanding of what prevention really is and what's actually possible. And I was curious to see if you had any reflections on that. I mean, Vic, I almost wanted to start with you based on your comment about Trojan mice.
I know you wanted to use the Trojan mice again, but for prevention, and I'd be interested to see, Barbara, what your views are on this. In a very highly pressured system where you're looking at financial recovery, elective recovery, very traditional views of performance often, there is a challenge to building in prevention and prioritising it for investment, time and resource when you're looking at negating a growth curve or bending the curve, or looking at benefits being delivered in generational cycles of 5, 10, 20 years, and trying to create that space within a system for prevention. and away from traditional prevention as well. So you're not necessarily looking at weight management and smoking cessation, but that wider determinants of health. So potentially one of our PCNs was looking at musculoskeletal challenges. They thought, anecdotally, that these cohort of patients had a coding for obesity, they had an MSK disorder and a pain relief prescription, and they were out of work. What we realised when we mapped those people's journeys through our system, that actually what came first wasn't the obesity, which was the assumption. It was an MSK injury as a result of work, which then meant they lost their employment and became obese, which means that the intervention and the prevention needs to happen in the workplace, which speaks to the wider determinants of health. So the engagement and the collaboration again becomes even wider, and that's another barrier that you need to consider. I wouldn't say it's a barrier, it's a challenge to managing prevention, as it may not be in any sphere of your influence. Does that make good sense?
Absolutely. Thank you. Barbara, since you got name checked, any thoughts on that?
Well, I think, you know, we would all prefer to do prevention more than treatment, but it is very difficult because there's only so much money to go around, and it's very difficult to deny the people who actually need treatment to do prevention. But that doesn't stop us. It means we have to keep trying. I think that what I think about what I've heard about pop health management and things is the kind of very individual nature of it, the personalised nature of it. This country has a very long track record of doing totally brilliant public health, way beyond what most other countries do. But just listening to the two of you talk about the way you're doing pop health management, yours, Jim, was this very personal. This is about an individual patient. And listening to you talk about the records, and you know, the other thing that we have in this country, which is kind of second to none, is the primary care record. And really, I wish it wasn't called the primary care record, because it's a personal medical record. And again, you can't really go anywhere else in the world to find that wealth of information in one place about our individual patients. So for me, I think one of the things that I know is happening with population health management is that ability to get down into what is happening to an individual patient. You might use the population to link your data set and get your analytics, but what goes on with that individual patient across a broad range of ways, because you know, some of the things that the broader determinants do are so unseen, and somebody, you know, my philosophy has always been, what in terms of health inequalities, if people with health inequalities had a waiting list, if they were queuing up to have their health inequalities removed, then we'd see the waiting list, and then it might come higher up on our list in prevention, whereas it's quite difficult to get it that prominence. But you know, in the final analysis, what all this is about is you really either have to change clinical practice or change patient behaviour, and everything else we do, whether it's policy, whether it's support services, it always comes down to one of those two things being the end point, which I think you two have so adequately talked about.
Thank you. Jim, since you're a colleague, I'm going to pick on you by combining two of the questions that have come in from Slido. So there's a question in here in terms of what does the proactive care element mean in practice? Is this a place for citizen involvement in understanding their own journey? And then there's another question around the notion of how can you make sure that PHM, whilst it's important to focus on managing resources in a fair and targeted way, is very much about the management of an individual, which is difficult, as they've put it in here, for that individual and for people who are trying to provide support. So I'd love to sort of get your view on how you see PHM enabling some of that.
Yeah, absolutely. If you put 7 6-year-olds on a small trampoline, you can predict that someone's going to end up crying, as my experience of children's parties have. If you have a certain situation, you can make some predictions about what's going to happen. And while predictions are kind of a bit nervous, because you don't know you're going to get it 100% right, you don't know exactly who's going to get injured, you can say that something is likely to happen. And you can do that with people. 200 people with COPD who have used steroids and antibiotics twice already in the calendar year and had 3 hospital admissions last year. Of those, a certain proportion are likely to go to hospital with the COPD exacerbation. Of those, a certain proportion are likely to have given permission for SMS texting, to have engaged with their digital tools. Of those, a proportion are likely to have a pulse oximeter at home, and a portion of those would be willing and able to learn how to use it. A certain proportion of them will have a home care plan given to them, and a proportion of them won't. A proportion of those that do will understand it because it's in a font and language that they understand, or another proportion won't. As you get to know that population in more detail, you can set up a system where you're proactively monitoring them. They might get a text every month, every week. It might be through an app that they are willing and happy to use. Some of them might get a certain type of key worker or specialist nurse involvement where someone gives them a call and checks how they're doing, or an advocate in their home helps them to test their pulse oximetry, for example. So how you go from population health management down to an individual is by increasing an increasingly narrow and specific view of the people within the group who aren't on a trampoline but have a significant condition or set of circumstances that mean you can help avoid for them a situation that came all of a sudden, that they suddenly needed hospital, their breathlessness had got too bad. And I saw a patient just like that yesterday who happened to also be my neighbour, who didn't realise that they needed a different set of antibiotics when they had a certain type of infection. They had the advocate of their daughter. And I just think you can be very specific and very proactive if you just consider slightly differently how you approach the care of different cohorts of people. And I could replace that condition, that set of conditions, with heart failure, lots of different cohorts. And you can rack that through to thousands of cohorts in the future, where they're all receiving a good concept of what best practice is, of proactive care, of what bespoke tailored design is for that cohort right down to each individual within it. And that's my vision of how we get proactive and support the citizen.
Thank you. We've got a bunch of questions coming in via Slido, which I don't think we're going to have the chance to get to. So if I don't get to your question, I'm sorry, but we do have a stand. So please do come and engage with some trampolining at any point. But I see a hand up in the middle of the room. So are you willing to stand up and introduce yourself? Are you brave enough to give that a shot on day one?
Okay, hi, I'm Hilary Pillin. I'm from the Association of Ambulance Chief Executives, representing all NHS ambulance services across the UK. Last week, we launched our consensus statement on the role of ambulance services in reducing health inequalities. A number of ways they can play a part in that, but one specifically I wanted to talk to you about was about the use of their data. And I notice, is it Vic? Apologies, I've got your name wrong. You talked about a lot of data sets that you're using in building up your picture of your population, but you didn't mention data from the ambulance service. And they have a wealth of information about your populations across your ICSs. And I'll just give you a quick example. One ICS approached their ambulance service and said, you're bringing an awful lot of patients from this particular area of our ICS into A&E. Why is this? And sure, it's far more than any other area. And so when they looked at the ambulance data, what they saw was actually this area was an area of high deprivation. The demands on the ambulance service there was much, much higher than any of the other areas, but they were actually proportionately taking far fewer patients from that area to A&E than they were from other areas, because actually what they needed was not an ambulance, it was something completely different type of care, maybe social care or whatever, and the ambulance service obviously do their best to direct them into the care that they need. So my plea is to anyone from ICSs in the room, talk to your ambulance services. They've got a lot of information you can use to build up your picture and help with population health management.
Thank you. Do you want me to put that to Vic?
Yeah, you can do.
I think it's a great statement. I just want to make sure we've got a question as well. So, Vic, did you want to come in?
It's an absolutely valid point, and it's a fantastic source of a wealth of information. The data sets I talked about in my couple of minutes earlier are what form the foundation of our linked data set. I'm going to speak on behalf of our Director of Intelligence and Analytics now, who knows far more about this than I do. I just get to play with the output, but we are going to be bringing in 111 data, ambulance data, Social RX, which is our social prescribing platform in Lincolnshire, and there is a significant programme of work to grow the linked data set. That's point one. The second point is that we also, from taking a PHM approach, don't necessarily completely rely 100% on a linked data set. So to your point about ambulance data, where we don't have something in a linked data set at the moment, we will tap into other intelligence resources that may not be able to be joined into the data set or aren't there yet. And also, importantly, which I haven't mentioned yet, qualitative data. It's not just about what we can put into tables in a number, but the qualitative evidence that informs the innovation that we we want to drive forward with PHM, and we can do that from many different sources. So absolutely fantastic point, thank you.
Thanks, Vic. I think we've got time for one sort of final question from Slido from a summary perspective, but just to acknowledge some of the questions that have come in. Secure data environments. We have a rare and unique stable of unicorns in our team who are analysts who can also be put in front of the public. Those of you who are analysts will appreciate that joke. Some of you may find it less entertaining. But please do come and talk to us about that. We would really love to. And it's also worth highlighting there are some questions in here about contracting models that actually converse to the system that we sometimes operate in now, incentivize ways of working together around PHM versus potentially creating perverse incentives. We're running a roundtable for DOFs and those in the finance space in the next couple of weeks. So come to the Optum stand, we'll happily give you some more information about that. The wrap-up question, I suppose, here is someone's asked for lessons learned, top tips for those systems that are much earlier in establishing an ICS-wide data set and population health management approach. And I wondered if I could ask each of you to maybe give one thing, one sort of piece of insight, one piece of advice that you'd want to share with people who are at different stages of that journey. Barbara, can I start with you?
Well, I suppose my advice is always about collaboration and people. You know, I suspect in ICSs where everybody's always really got on well in the past, they'll be well on their journey of doing things together. Some are better at technology and some aren't. But this is about relationships, and as long as there's a will, you know, ICSs have a big challenge. They're a partnership model rather than necessarily an authoritarian model. I think it's the right model. So for me, it is, you know, look what's being done. There'll be a solution somewhere else for everything that you need to do, but actually use the relationships that you can have in an ICS to drive this forward.
Thanks, Barbara. Jim?
Yeah, I think work with your data protection officers. Make sure they understand what you're trying to do and make them feel comfortable in their role of protecting data and ensuring privacy and the data principles are adhered to, but that they have the facility to empower the system to do more if they want to. To start with what you've got, and alluding to another question that's come in about all the individual pressures, to make sure people recognise that they are deep underwater, it feels like, and overwhelmed a lot of the time. But sometimes working with just hospital data, as I have, looking at learning disabilities and finding that they use 4 times the amount of urgent care than people without learning disabilities, you can actually reduce the pressures with some effort talking to the people on the front line, the learning disabilities team, for example, those who really understand what it's really like and aren't up the abstract too far. And so I think, and starting with PHM as a methodology with what you've got, rather than waiting for the best data set.
Thanks, Jim. Vic?
So building on what's already been said, I think from my experience over the last 3 years in this role, I would say start working with the willing, allow organic growth, build your relationships and your networks to get those Trojan mice running. And secondly to that, when you're working with the willing, try to come alongside with the methodology, something that's already a priority for them. Go with something that you can support, especially if you're looking at primary care, where they're already working with a challenge, with their head underwater, where you can come in and support them and meet them where they are. And that's an ethos, I think, from the whole of PHM, is you meet the resource, the people, and the people working with them where they are.
Great. Thank you so much for joining us today on the panel. I'm sorry we only had a short period of time, but again, come to the stand. We'd love to debate, discuss, learn from everybody that's here with us today, but we really appreciate your time. Thank you ever so much for coming to the session.